Good morning, and welcome to our presentation here today. Thanks for your patience. We are ready to get started. Are you guys ready to get started? Excellent, I think so. Okay, I'd like to say just a couple of words about our featured presenter today. She's going to say a few things about herself when she comes up here as well. Lydia Bartholow, DNP, PMHNP, CARN-AP, is a doctorally prepared psychiatric nurse practitioner, substance use disorder specialist, and educator located right here in Portland, Oregon. She provides direct care for clients with co-occurring disorders, as well as overseeing the safety and clinical quality of all patient care and providing clinical visions to addiction and mental health services. Lydia completed both her master's and her doctorate in psychiatric nursing at Oregon Health Sciences University. Her doctoral work focused on the intersection between psychological trauma and substance use disorders. Lydia lectures across the state on topics such as medication-supported recovery, trauma-informed care, and difficult conversations. She carries a deep commitment to harm reduction, health justice, and holistic care. Lydia lives in Portland, Oregon with one child, one pit bull, and one husband. So don't mess, and one cat. Don't mess with her. Please give a warm welcome this morning to Lydia Bartholow.
Thanks. So first of all, who am I? I love it when Paul introduces me because he's got this very news broadcaster presentation. It always sounds really fancy. I never feel that fancy. I have a doctorate, but I very much identify as a nurse first. And one of the reasons I feel really committed to nursing, even though what I do is in some ways more like a medical doctor, is that, and this is particularly tied to trauma-informed care, one of the things that differentiates nursing from the rest of medicine is that nurses are really interested in the patient experience and not just the outcomes. So if you go into the nursing literature, like the Nursing Academy, most of the nursing research is not just about did this one work better than this for resolving this pathology. Most of the nursing research is what was the patient experience when they were in the ICU? What was the patient experience of XYZ intervention? And that's particularly important in trauma-informed care because, as we'll get into later, trauma-informed care is not about the intervention and the outcomes. Trauma-informed care is about the experience that people have while you're serving them the intervention and the outcomes. So I think nurses are particularly well-placed to focus on trauma-informed care. I'm also, in Paul's introduction of me, I think it said that I was responsible for a whole bunch of stuff like patient care, responsible for, I don't know, I used to be responsible for some finance stuff, all that stuff. I recently retired from being a director, so right now I'm just doing clinical work. It's what I really, really love. That was a couple weeks ago, so I'm no longer a director of anything. And I am a person in long-term recovery. So when I speak on this material, I'm speaking both as someone with an academic history in the material and as someone that is a clinician interfacing with this material on a regular basis. And then I'm someone in long-term recovery who also has a history of trauma. So my ACEs score, which we'll go over in a little bit, is pretty high. So I'm also speaking from a personal perspective about the material. And then, of course, there are other parts of my identity that really inform the way that I think about things. I think one of the most important is being a nurse and a person in long-term recovery, but there are all kinds of parts of our identities that show up. And when we're in large groups like this, I think it's important to sort of name some of those things. So I am definitely an educator, and I think a lot about how to make information accessible to a large number of people. So hopefully that will also show up in today's work. Let's do some housekeeping before we dive into the material. Bathrooms, I believe, are that way. We weren't speaking of the rom-com where everything went right. We didn't know we were going to be in this room until pretty last minute. So I just left it blank. Bathrooms are somewhere. We knew there would be bathrooms. We just didn't know quite where. So they're over there. I think there's going to be snacks and water. There's tea throughout the day. You guys have all got fidget toys on your tables. Please use those amply as we move through the material today, especially some of the neuroscience material. When you feel like you're getting a little bit overwhelmed with neuroscience, grab a fidget toy and stop thinking less about the details of what I'm talking about and let your body think about those fidget toys and then think really, really conceptually about what I'm talking about. And I promise you'll get the big concepts by the end. We're gonna have a break at 9:30-ish, although again, we're pushed back a little bit, so it might not be exactly 9:30. And then we'll have lunch around 11:30, and we're probably gonna shrink lunch a little bit because we started a little bit late. You guys didn't actually want a whole hour for lunch, did you? No, okay, that's a really long time. All right. So, very large group today. We had almost 160 people signed up via CareOregon. And so because of that, I thought it would be useful to start out just with some group agreements. First one is move up, move back. And you guys should feel free to add some if you want, but move up, move back. How many of you guys, you can just raise your hand, are familiar with this concept? Okay, great. So for those of you that aren't familiar with the concept, the idea here is that when you're sharing space with people in a group, we're gonna do some sort of self-policing where we try not to take up too much space. And we also, if we're people that tend to be a little bit quieter, try to encourage ourselves to speak and really engage with the material. So how many of you guys have ever been to a meeting or a talk and there's like one person and they just take up all the space? Yeah, so we're just gonna try to avoid that today. I want you to engage in group activities as tolerated. So because it's such a big group, I'm gonna try to do some breakouts. Usually I do a lot of sort of workshopping and asking questions, and I'll do that today. But because there's so many of us, I want you guys to be working together at tables. And for some people, that just doesn't feel comfortable. So please take breaks from that, or don't engage in those at all if that's what works better for you. If you're not gonna do the group activities, I would just encourage you to try to jot stuff down. So kind of do them internally with yourself. Tend to yourself throughout the day, large group. I don't know about you guys, but I already feel really warm. Is it really warm in this room? Yeah, so get up, take breaks. I see some people being like, no, I'm freezing, and some people are really warm already. Get up, take breaks, get water, do the things you need to do so that you feel best. And then I just have a couple of assumptions when we start the day. And the reason that I put these assumptions out there is also because it's sort of attached to move up, move back. Sometimes I find that there are things that we get stuck on throughout the day, and if I just start by saying these things aren't up for discussion, it can sometimes be useful to save the rest of the group time. And when I say these things aren't up for discussion and these things are just assumptions that we know to be true, that doesn't mean that I'm not available to talk about it. I always want to talk about things. Come up to me at lunch. We definitely can have dialogue if you disagree with some of these assumptions. But it's not something that I want us to get stuck on and spend a lot of time around as a larger group. So the first assumption is that pharmacotherapies to treat addiction are a legitimate form of recovery. So we're just not going to have a big discussion in here today about whether, say, methadone or Suboxone is actually allowing someone to engage with recovery. That's just like off the table. Happy to talk about it over lunch, but it's not something we're going to spend time on today. In this room today, what I'll be talking about just assumes that those are legitimate forms of recovery. And then the second thing that's just kind of not up for discussion and helps us move through the day without getting caught on things is the acknowledgement that when we talk about trauma, we're not just talking about trauma as an individual experience. And sort of why I started thinking about this and the need to talk about it out loud is I did an interview with a local news station, and it was about the opioid epidemic. And I had been invited on as sort of an expert to talk about opioids, what causes addiction, and then a little bit about the opioid epidemic. And of course, I mean, this isn't news to any of you, I gave what I thought was like this beautiful interview about social connection and trauma and sort of these things that make us more vulnerable to developing addiction. And then what ended up airing was like maybe about 2 seconds, and I think it mostly focused on fentanyl. And then they said, and Lydia says that what causes addiction is a personal problem. And I was like, oh, that's not at all what I was trying to say. And so I started thinking about the ways in which we need to be really, really overt when we talk about trauma. When we talk about trauma, we're not just talking, and we'll come back to this, we'll build on this idea throughout the day. When we talk about trauma, we're not just talking about individual experiences that people have. We're also talking about poverty, we're talking about racism, we're talking about transphobia. So when we talk about a trauma, we're assuming that we're talking about larger pieces of structural violence. And again, we'll come back to this throughout the day. It's just, I want to start us off with the underlying assumption that that's what trauma is. It can be both an individual experience and it can be something that exists in larger structures of violence. Do you guys have any agreements you want to add? Okay, great. So let's do a little bit of grounding, and I always put this in here totally selfishly. This is actually for me to take a moment and just like relax and remember why I'm here, because the hardest part of a 6-hour talk is always the first half an hour, except for today, when the hardest part of the 6-hour talk is going to be when my voice goes out. That's going to be the hardest part today. So what I want you guys to do, and we would do this sort of as a whole room, but since there's so many of us today, I want you to just turn to the person beside you, and I want you to share one time in the last week you felt like yourself, that you really felt like sort of your best self was showing up, whether it was work or home, and then why you do the work you do. And it's really quick, so 2 minutes and then trade. And I'll tell you guys when 2 minutes is up. So a time in the last week you felt most connected to yourself or most like yourself, and then why you do professionally the work that you do. All right, so that's the end of the 2 minutes. So we'll come back together as a larger group. And I'm wondering if a couple of you would consider sharing why you do the work you do. Oh, and yes, oh my gosh. And Paul came up and reminded me that if you're going to share, let's have the mic.
Hi, I do the work I do. Hi, my name is Mac D. I'm with Sensitive Concern. I do the work I do because I am the work I do. You know, I stand on the shoulders of giants here. And like Steve was telling me, you know, he's the same way. And we're not the only ones. You know, we grow, you know, this is part of our recovery, helping people with their recovery. And there's no better payback than that. That's just like the ultimate, isn't it?
Thank you. Maybe one more.
Hi, I'm Lindsay. I work at LifeWorks in the adult outpatient program. For me, doing the work that I do is really important because it's all about like providing access to care for folks who don't typically have access to care, especially folks that have like complex and developmental trauma and trans youth. And so I really am happy that I can work with those folks and they can actually like come in and have somebody that looks like them, that has had similar experiences as them, and it's there. They don't have to access like specialty care.
Great, thanks. So I want to do just a moment of mindfulness now to sort of get ready for the day. Very, very briefly, I want you to try to ground in to why you do the work that you do. Sort of like tap into your heart, think about what you just shared with the person, and just sit for a second and try to, you can close your eyes if you want, although that's not necessary. You may find that you want to scan the room before you close your eyes, if you are someone that wants to close your eyes. And just feel the chair holding you up. Notice a couple things happening in your body. How tense or not are your muscles? How's your breathing? And try to sink into that feeling around why you do what it is that you do. And And then when you're ready, we're gonna come back together as a group. And we're gonna do some group work around what causes addiction. And before we do this, I would love to know a little bit more about who's in the room. So I'm just gonna, all we're gonna do is sort of, raise your hand. Do we have any RNs in the room? Yay, nurses, awesome. Okay, great. Social workers? Awesome, love me some social workers. Okay, medical doctors? All right, awesome. Peers? Nice, I love that. Alcohol and drug counselors? Okay, great. Who did I miss? Pharmacist, awesome. What's that? Resident services programs, great, thank you for being here. And pharmacist, I heard. Case managers. Did you want to say something? Oh, got it, okay. Frontline workers, great. Life coaches, okay, wonderful. All right, so we have a good array of people. Ooh, prevention educator, awesome. One more. Employment service, oh my God, thank you. That's great. Okay, great. So we've got all these different disciplines in the room, which means we should have a pretty well-rounded understanding of what causes addiction, right? We've got all these different disciplines, all these different ways of thinking about humans and how they interface with the world and what makes them resilient and successful. So we're just gonna jot down what causes addiction and who addicts are. And for this initial exercise, I want your demons to come out. Let some of those like underbelly thoughts that you have, like let's say you're working with a client and you start to get frustrated because they're not changing as fast as you want them to change, or their values aren't the same. Start thinking about what larger cultural narratives are, and again, let your underbelly thoughts show up. So we're gonna do it in a group, and you guys have got 5 minutes. And what I would do is I would pick a scribe, one scribe for the table, and just jot down everything you can think of about what causes addiction, and then who addicts are. And I'll put on a timer for 5 minutes. All right, so that was your 5 minutes, and it seemed like things were sort of dying down a little bit. I know the slide says 10, which is terribly not trauma-informed of me. You guys got 5 minutes. Did you guys feel like you got enough time to jot down some core paradigms? What's that? A couple more minutes? Really? How many other people feel like you need more minutes? Okay, I think we're gonna move on, because I didn't see a whole lot of interest in more minutes. But be thinking about it. If you felt like you didn't have enough time, hold that stuff in your mind. So just really quickly, I want to go around the room and see if we can pull out some of the core paradigms. Who wants to share one of the core paradigms that came up at your table?
About narratives?
Yeah.
So media narratives, people who use drugs are immoral, thieves, liars, sick.
People who use drugs are immoral, thieves, liars, and sick. Mm-hmm. Is that it? Thank you.
That it's their choice and they enjoy it.
Oh, that's so good. It's their choice and they enjoy it. Yeah.
We talked a lot about poverty.
Poverty as a cause.
And social determinants of health.
You guys did not let your demons come out. Holy smokes. Okay, so poverty and social determinants of health. Absolutely.
Can I just yell? Is that okay?
Oh, man.
Criminals, homeless, people with mental health, people of color, privileged, upper class, and
that's not in the media part, but those people can be affected by addiction too, intelligent people.
Yeah, that's great. Yeah, I mean, I think one of the core things the media does is says if you're an addict, you're probably a person of color. If you're a white person that struggles with addiction, you probably are sick or you have a disease, right? Yeah. All right, what else we got? All right, one more, yeah.
Well, we got stuff like stress.
Distress?
Distress as well.
Distress?
Distress, getting the pressure off.
Yeah.
You have family influence. I feel sorry for people that never had a chance. Like for the little kids. I started getting high when I was 9 because I had a bigger brother who's a few years older. It just, and so people never had a chance. They don't know any better. I was talking about, it's peer influence, but it wasn't peer pressure for me. That's just what everybody else was doing, so I did it too. And so, so there's a myriad of circumstances, and it was covered that it's multifaceted, and it's really hard, because of the societal issues and stuff, that it's really hard just to pinpoint. But there's a lot of common ground.
Yeah. So one of the things, I want to highlight some of the things I heard that are like the core cultural narratives that we hear every day about addiction. We hear that addiction is pleasurable. We hear that it is a choice. We hear that people use because they like to get high. And one of the things that we hear that I very rarely, I feel like this is going away as part of our narrative, but it's still sort of hidden in our cultural conception of addiction, which is that drugs cause addiction. By which I mean, if someone uses cocaine 3 times a day, every day for a month, they're gonna be addicted to cocaine, right? Don't we have that belief? If you start using opiates and you use opioids every day for 2 weeks, you're gonna be addicted. That still follows as kind of one of the threads of what causes addiction. So again, let's just review some of the sort of core cultural narratives around what causes addiction is pleasure and a enjoyment out of getting high, quote unquote, that it's a choice, that the drugs themselves cause it, and anyone who interfaces with those drugs regularly will become addicted. And there's a narrative that you would only interface with those drugs because you had a choice to do it and you were an immoral person. And then some of the things I heard you guys say about who addicts are liars, thieves, and criminals. Does that sound accurate? Now, you in the room may not carry this belief, but I want you to think about larger the stories we're told about this disease. Do those sound pretty accurate, and have I missed anything? Oh, mental health, yeah, that there's a huge mental health component. So people that use are crazy. Yep. Wait for the, that thing.
No, I heard somebody say rich people too. So, this crosses all cultural bounds. No one's safe from this. It's everywhere.
Yes, and the cultural narratives that we are told, especially by the media, are that this is primarily an addiction of a disease of poverty, right? Is that the story that you guys feel like you're being told?
I have a quick question. Are you making the distinctions between addiction and alcoholism?
Oh, I'm including alcohol under the umbrella of addiction right now.
Okay, I just wanted to get that clear.
Yeah.
Because it seems to be one and the same to me anyway.
Yeah, thanks for clarifying. Okay, so I want you guys to hold that. I want you guys to hold these sort of larger paradigms or stories that we're told about addiction, and then hold it sort of in your mind, and we're gonna pivot and we're gonna start talking about trauma now.